Welcome, everyone. It's a great pleasure to be here today. So my name is Alexandra Calmi. I'm the head of the HIV/AIDS unit at the Geneva University Hospital. And we will begin straight away as we only have 1 hour and there is a lot that we would like to get through. So it's really my pleasure to moderate this webinar today. And this is the final webinar in a series of HIV-related stigma hosted by the International AIDS Society and the People Living with HIV Stigma Index partnership. The previous webinars focused on the importance of evidence-based advocacy intervention, the need to address internalized stigma experienced by people living with HIV, and ways of promoting human rights in HIV response. Next slide, please. So today we will be focusing on stigma and discrimination in healthcare setting. We will begin by looking at some of the evidence of the problems faced by people living with HIV, in particular women. We will then have a short video to watch, followed by a panel discussion where we will have an opportunity to look at some of the approaches used to reduce HIV-related stigma and discrimination. Next slide, please. So I have a few logistical points to go through with you. We will not be taking questions from the chat, but if you have any question for the speakers, please write them in the Q&A box. The webinar is available in French, English, and Spanish, and to choose your language, select your language channel at the bottom of your screen. And please note that this webinar is being recorded and will be available on the IAS Plus learning platform. Next slide, please. So now it's the time to introduce our first speaker, Karen Dunaway. Thank you, Karen, for being here with us. So Karen is a young feminist activist from Honduras, dedicated to advancing gender equality through advocacy and peer-led research. As the Global Programs Officer at ICW Global, she contributes to the Stigma Index 2.0 Technical Assistance Program, empowering networks of people living with HIV. Karen has developed gender advocacy tools and led workshops on intersectional gender analysis. Born with HIV, she draws from her personal and professional experiences to drive impactful community-based research and advocacy initiative. So thank you very much for being here with us, and the floor is to you, Karen, to start.
Well, thank you, Alexandra. Hello, and thank you, the IAS, for having me, and also for joined the Stigma Index partnership to have this series of amazing webinars. It is very nice to be in the call with very powerful women. I have a brief presentation prepared, and I'll promise I'll try to keep it in under 10 minutes. There's a lot of information I don't want to leave out, and I'll do my best to speak slowly for the translation. That being said, and mindful on the time, I will just dive right in. The presentation, what I'm going to talk about, it's the ICW global scan of coercive practices. In July, we launched the first scan about coercive practices, and this scan looked at reported experiences of women living with HIV who have faced various forms of abuse by healthcare providers. This include physical violence, verbal abuse, and denial of healthcare. What we aimed with this report is to bring a light on the recent experiences of coercion, mistreatment, and abuse, while also in the report, we dig into the works and advocacy of several networks of women living with HIV to work on these experiences and these practices. And also documenting the experiences through our own voice. But first, before sharing the findings, I just want all us to be on the same page on what is coercion. Next. These categories represent the type of coercive practices most commonly reported and are the ones covered in our study, in the research. But we acknowledge that this list of coercive practices is not exhaustive, and there may be other experiences of coercion not addressed in this report. But for us, what is coercion? It's advice not to have a child, or told not to have children, or not to have another children because of HIV status. Advice to terminate a pregnancy because of HIV status. Pressure and encouragement to undergo sterilization. Sterilize without knowledge or consent. Denials of contraception. Pressure to use a specific type of contraceptive methods. Must use contraception in order to get HIV ARV treatment. Pressure to use particular birth delivery method, particular infant feeding practices, to have a pap smear test, a vaginal examination, and undergo female genital cutting or mutilation. Next, please. Well, mistreatment and abuse experiences by women living with HIV are also prevalent and occur both independently of coercion, but in ways that also support and reach to coercion. Mistreatment and abuse reinforce gender inequalities and undermine bodily autonomy and represent violations of sexual and reproductive health and rights of women living with HIV and all girls and gender non-conforming people as well. Next. This report's methodology combines both the qualitative and the quantitative side approaches. Is integrating insights from the PLHIV Stigma Index 2.0 and a scope and desk review of existing literatures. It was guided by a global steering committee of 16 powerful women living with HIV, and we had 3 core elements. That is, the gender analysis is a focused gender analysis of recent stigma index data with the help of the technical assistance of Johns Hopkins University, representing over 26,500 women from 3 regions: Sub-Saharan Africa, Latin America, and Eastern Europe. We also had a literature review. There's a comprehensive scope and review of the studies on reproductive coercion, and also we had a qualitative insight. That is, we had key informant interviews. We had an online survey in 5 languages. It was Arabic, English, French, Russian, Spanish. We did in-depth local interviews and case study development. This to capture the voices and experiences of women living with HIV across the globe. Next, please. And what is the stigma index? The quantitative analysis was done using the data from the PLHIV Stigma Index. This is a socio-behavioral study that uses a standardized methodological approach. The Stigma Index has been developed in more than 100 countries and have completed this study, and over 150,000 people living with HIV have been interviewed. And the Stigma Index study is run by the international partnership comprised of ICW, GNP+, UNAIDS, with the technical assistance of Johns Hopkins University as well. Next. And with that, I already said, we used the data of 23 countries across the 3 regions. We created a data set of 26,502 women living with HIV that was represented. Next. Thank you. And coming to the key findings, 3 main findings I want to highlight before getting more detailed. 4.4% of women living with HIV reported experiences of coercive practices in the past 12 months. Nearly 20% of women living with HIV who participated in the 2.0 study reported experiencing some form of coercive practices in their lifetime. And across regions, coercive practices were concentrated around pregnancy and infant feeding. Slide 2. Women living with HIV continue to face high levels of coercion with reproductive health care. This especially around contraception and family planning, pregnancy and infant feeding, and even irreversible sterilization. You can see that in Latin America, 14.1% of women reported coercion to undergo sterilization, 13.2% experienced pressure around pregnancy and infant feeding in the past years. And in ICA region, 8% reported coercion in similar areas, while in the sub-Saharan Africa, 5.2% of women faced these practices within the same time frame. And across regions, 4.4% of all women living with HIV surveyed reported coercive practices in the past year alone, translating to thousands of women experiencing this annually. We can see that Latin America showed the highest levels of both recent and lifetime coercion, followed by ICA and Sub-Saharan Africa. Next. Here we can see the distribution of women living with HIV across all countries, reporting experiences of reproductive coercion related to pregnancy and infant feeding in the last 12 months. The proportion of women who reported this type of coercion was varied, with estimates as high as 25% of women living with HIV reporting coercion related to pregnancy and infant feeding in the last 12 months. Next. Women, we also wanted to understand the experiences of contraception and family planning. And women living with HIV also reported experiences of reproductive coercion related to contraception and family planning, with estimates as high as 18% in Nicaragua and 20% in Bolivia. This coercion often takes form of being pressured into specific contraceptive methods, sometimes as a prerequisite for accessing HIV treatment. In some cases, women were limited to access to condoms, with a judgment that women with HIV should restrict their sexual activity. Next. Sterilization. Sterilization is a permanent and irreversible form of contraception. Sharing information about it as an option can occur. However, pressuring or recommending sterilization based just on a woman's HIV status crosses into coercion. Forced and coerced sterilization in the last 12 months was reported among women living with HIV across regions. These estimates only include experiences in the last year and do not capture the experiences of sterilization occurring more than a year before the data collection. Next, please. I'm going a little bit faster because I am mindful of the time. Women living with HIV reported experiences of abuse by healthcare providers. This include physical violence, verbal abuse, and denial of healthcare provision. Verbal abuse, you can see, was the most common type of mistreatment by healthcare providers, with 3.9% in Sub-Saharan Africa, 4.4% in ICA region, and 6% in Latin America. Next. We also did an intersection analysis based on different identities of women living with HIV. Women living with HIV who reported engagement in sex work, drug use, or had disabilities reported experiences coercive practices at higher rates than other women living with HIV. We also saw that the age difference, younger women living with HIV and women living with HIV who were migrants were also most likely to have experienced coercive practices than older women and women who were not migrants. Sex workers, you can see in Latin America, who participated in the Stigma Index, reported higher levels of coercive practices in every category. In Sub-Saharan Africa, women with a history of sex work were 1.9 times more likely to experience coercion related to family planning in the last 12 months. And in ICA region, women with a history of sex work were 1.5 times more likely to experience coercion related to family planning. Next. And among women living with HIV of reproductive age who participated again in the Stigma Index and report the use of drug use, 4.4% of women in Sub-Saharan Africa, 5% of women in ICA region and 11.4% of women in Latin America reported experiences of reproductive coercion related to contraception, family planning in the last year. Next. At the beginning of the presentation, I said that we also wanted to document our own voices. This report was led by the Global Steering Committee of Powerful Women across the world, and we also did key interviews, national interviews of women who have experienced this type of practices. This is a quote from an interview of a woman living with HIV in Cameroon. I was told it was dangerous to have a baby and was pressured to be sterilized. I experienced pressure not to breastfeed because HIV can be transmitted through breastfeeding, but since I had no way to feed the child, I gave him the breast, and today my child is healthy. And another quote from a young woman living with HIV in Kenya. Early this year, we were helping one woman who was jailed for non-Nigerians. She was struggling with drugs. She didn't go for her clinic appointment and just had a baby. She was put in prison with her 3-year-old child and 3-month-old baby until her baby was 18 months so she could take her medicine and breastfeed her baby while being observed by law enforcement agents. It took us a long time to convince authorities to let her go home and get psychosocial care at home instead of in prison. There is a lot of a stigma for sex workers and women who use drugs at the health facility. Next. Our research found that coercion, mistreatment, and abuse experienced by women living with HIV, including women from key populations, is frequently not reported or even underreported. It's persistent, it's widespread, normalized. It's also systematic and a structural problem reinforced by these harmful social norms and out-of-date policies and practices, and also have immediate, medium, and longer-term negative impacts of the well-being of women living with HIV. This also includes fear of accessing services and disempowerment. Next. And our findings also reveal that sexual and reproductive health programs often prioritize the interests of others over the autonomy and rights of women living with HIV. Medical and legal professionals enforcing HIV prevention practices frequently overlooked women's consent, leading to surveillance, punishment, and judgment. Also, intersecting HIV-related stigma, gender norms, and limited access to justice further drive coercion and abuse while reproductive healthcare settings. Next. Our report is out. You can find it in our website at wlhiv.org/reproductive justice. We also have the executive summary in Spanish, French, and Russian. And please let me know if you have any questions. Feel free to dig in and read into other reports. We have a call to action and policy recommendations based on our findings as well. Hope I don't get over the 10 minutes. I'm sorry, and thank you.
Thank you very much, Karen. It is extremely interesting, and also to show the differences across different regions of the world. So I'm sure there are many of you who have questions or comments that you would like to share with Karen, but you will have to wait a little bit. Before we come to the panel discussion and an opportunity for question, we have a short video to share with you. This was produced by ICW and shows the challenges women living with HIV have faced in Argentina. So please go ahead with the video.
Esta es una historia de lactancia, mujer con VIH y criminalización. Melody y su familia estaban muy felices con el embarazo. Melody tiene VIH. Estar para las mujeres con VIH significa enfrentar muchos mitos basados en la desinformación y el estigma. En el 2016, la Organización Mundial de la Salud declaró que las mujeres con VIH con carga viral indetectable podían utilizar la lactancia materna de la misma forma en que lo hacen las mujeres sin el VIH. Sin embargo, ese día a Melody le informaron que en el área de neonatología no iban a permitirle amamantar a su hija y que tendría que elaborar un plan de parto respetado que sería observado por un grupo de profesionales. Para la semana 36 de gestación, Melody estaba nerviosa. Aunque había asistido a muchas consultas, controles antes, esta se hizo interminable. Le dijeron que estaba mal que amamante a su hija, que era irresponsable, ilegal, perjudicial para la salud porque atentaría contra los derechos de las niñas. Como si esto fuera poco, le informaron que debía presentar una autorización judicial, que podía buscar otra clínica que le permitiera la lactancia materna para realizar el parto allí. De pronto, Melody se preguntó a sí misma, ¿soy una mala madre? ¿Mi hija va a odiarme en el futuro? Cuando Melody llegó a la semana 37 de embarazo, comenzaron las contracciones, por lo cual fue a la clínica. Las cosas se pusieron peor cuando ingresó al consultorio una trabajadora social que le escuchó una notificación del juzgado de familia número 6, que les negaba la posibilidad de amamantar a su hija a través de una medida cautelar. Melody no quiso firmar esa notificación y buscó ayuda con ICW, la comunidad de mujeres viviendo con VIH de Argentina. La clínica, en lugar de respetar los derechos de Melody y su hija, decidió denunciarla ante el juzgado criminalizándola por su decisión de amamantar. De lo que sucedió esa mañana en la clínica, Melody se sintió muy preocupada. Además de tener contracciones, parecía que ella y su pareja estaban cometiendo un delito por desear amamantar a su hija. Una policía apareció en la puerta de su casa informando que tenían que presentarse al día siguiente en el juzgado y que podían enfrentar a la justicia penal por desear amamantar. Entre tanta preocupación, pudo conocer a las compañeras de ICW Argentina, que además de brindarle información y aceptar ayudarla para la presentación en el juzgado, le hicieron sentir acompañada y más segura. En el juzgado, ni la jueza responsable ni el defensor de niñez quisieron recibir a Melody. Pero ella sí quiso dejar testimonio de por qué no era un delito amamantar a su hija y cómo la criminalización realizada por la autoridad evidenciaba el estigma y la discriminación que existe hacia las mujeres con VIH que eligen amamantar. Al día siguiente, el juzgado cambió de notificación, quitándole a Melody y su pareja las responsabilidades civiles y penales, aunque seguía recomendando cumplir con las directrices de la maternidad sobre la lactancia para mujeres con VIH. A los 2 días, luego de un parto satisfactorio, nació la hija de Melody. La criminalización hacia las mujeres con VIH por una posible transmisión hacia sus hijas representa una violación a los derechos humanos. Vivir con VIH no puede ser considerado un crimen y los efectores de salud no pueden criminalizar a las mujeres.
Thank you very much for this video to the organizers. So now I am pleased that we are now able to begin our panel discussion. Karen is being joined by Emma Diamera and Erika Spielmann. So Emma is the Executive Director of the Educational Assessment and Research Center, EARC, a women-owned NGO in Ghana. Emma has 20 years of experience in research and development, specializing in monitoring and evaluation. Through EARC, she has successfully worked with health sector organizations to address HIV stigma that occurs at multiple reinforcing levels through the use of the total facility approach. Erika Spielmann is an experienced public health professional with a background in clinical practice across the United States and North and Sub-Saharan Africa. Her work has primarily focused on HIV and STI prevention, with an emphasis on adolescent and key populations. Currently, Erika is with the WHO, World Health Organization, where she co-leads initiatives focused on addressing stigma and discrimination in healthcare settings, promoting the health of young key populations, advocating for condom use and other cross-cutting issues. So welcome everyone, and thank you for being part of this panel. Maybe I can start with some questions to you, Emma, if you agree. So first, Emma, I know that in Ghana, you have taken a total facility approach to stigma reduction. Can you explain to us what this has involved? please. We don't hear you, Emma.
Sorry, I was on mute. Thank you for the opportunity. The total facility approach is basically an innovative intervention aimed at reducing stigma amongst health workers, increase access to health services, and improve HIV outcomes. And so how we have done it in Ghana is by starting with a baseline survey in a particular facility we are working in. So the questionnaires will find out about some of the stigmatizing behaviors of the facility workers, and this helps us quantify these behaviors. Then, based on the findings, we meet with the facility management and try to reach as many of the facility staff as possible. Then we disseminate our findings to them. And almost invariably, you find out that the health workers are shocked by the results of the analysis, because if you ask them, what do you stigmatize in this facility? The first thing is, yeah, professionals, we don't stigmatize. With the data, when we go back to them, we tell them to interrogate the data, and they find out that some of their behaviors are stigmatizing. Some of them, they are not aware that they are stigmatizing behaviors. So based on that finding, we develop an intervention. And the intervention starts with a TOT, a training of trainers. The TOT brings workers from the facility into about 8 workers into a training, so that they go back to the facility and train their own staff, so that they feel a sense of ownership. So after they have come for the 5-day training, they go back to their facilities and try to train the whole facility. That's why it's called total facility approach. And the training is very innovative. It brings together doctors and cleaners in a section. And this helps to create bond amongst the workers. So after the TOT, they go back to the facility, try and do a step-down training for as many of the facility staff as possible. Once this has been done, during the training, during the step-down training, they identify people who are in the facility who are passionate about reducing stigma. And these people are selected to form a stigma reduction champion team in the facility. So these people come together, and based on their facility requirements, they develop some interventions, little interventions in the facility to help reduce stigma among their workers. And they are given a little seed money to help them develop their activities. So that's basically what the total facility approach entails.
Thank you very much, Emma. I have another question for you. So what do you think has been the key of the success for your total facility approach? And especially what could be replicated in other countries? So what is we understand it works, we understand the total and comprehensive approach, but what do you think could be replicated, and how can we help other countries to take the example and your model on hand?
Yeah. So the first thing is the data collection. Once you quantify the data, you are able to come up with actionable drivers that you can use to describe the extent of stigma. And also, after the intervention, we go back and do an end-line survey and you see there's been a reduction in some of these stigmatizing behaviors, like wearing double gloves. And so once you bring it back to the facility and they understand more, it helps reduce stigma in the facility. Also, the total facility training is very innovative. It's very simple to replicate. It doesn't involve high-powered PowerPoint presentations and all. You just use ordinary flip chart papers, and so it can be done anywhere, and it's very, very participatory. So you realize that because of the participatory nature of the training, most of the facility workers remember the training, and it helps them recognize some of these stigmatizing behaviors. And when somebody is being stigmatized, they check one another. So then also, because the training is done by the facility staff, the step-down trainings, it's kind of owned by the facility. And so there's a sense of ownership. And all the interventions they develop, the champion team develop, are facility specific. And so there's a lot of ownership, and also there's a lot of support from management, which helps them keep the intervention. So basically, it's important that to be able to sustain and scale up in your facility, you have to involve management. Once management agrees to the intervention, it runs smoothly. And so, yeah, those are some of the ways it can be sustained. That is very replicable. It's been used in other countries like Tanzania and Thailand. So other countries, and there is a comprehensive training manual which can be used and can be adapted to any situation.
Thank you very much, Emma. Maybe I can just add another very small point. How many people are involved in a total facility, like in your institution, for example? How big it is, just for us to understand?
Okay, so a total facility ideally wants to train 100% of the facility. So everybody in the facility, but realistically, you won't get all of them. So I think we are able to reach about 80% of the population, the staff population in the facility.
Thank you. Thank you very much. So now I have some questions for Erica. Thank you. So what are the key messages, Erica, you hope people will take away from the WHO technical brief, Ensuring Quality Healthcare by Reducing HIV-related Stigma and Discrimination? Can you tell us about this, please?
Great. Thank you, Alexandra and Karen and Emma. Thus far, fantastic information. Just a quick, WHO launched this technical brief at the 2024 IAS just to update people, ensuring quality healthcare by reducing HIV-related stigma and discrimination. And I have a couple takeaways, and I will try to be succinct and brief. But it's basically a document that's really focused on healthcare settings. So that's first and foremost. So we know that health facilities and communities are central to driving change, and that there are interventions available, such as what Emma was speaking about just now, to tackle stigma and discrimination. And while laws and policies are equally important, tools in addressing stigma and discrimination, the brief really focuses on actionable interventions within healthcare facilities and communities. So when looking at this, that's, I just want to make sure everyone is aware of the focus. Secondly, one action is not enough for sustained change. We know that any change, but especially around behavior and stigma and discrimination, requires a combination of strategies at different levels, and not just a single approach, including personal, which is why there were previous webinars on internalized stigma, community, environmental, facility level, and beyond. So keeping that in mind, some of the examples that we give in the technical brief, you might think, oh, well, you do want this one intervention, nothing has changed. It involves multiple interventions. And then also we really need to be looking at the whole picture of a person. So approaches that recognize multiple sources of stigma, such as the total facility approach that focuses on intersectional stigma, right? Which we know can be across race, socioeconomic, mental health, so many that when someone comes to a provider or into a facility, we really need to be approaching it through the lens of intersectional stigma. What else is going on, and how else can we enhance health and quality of life, particularly for the most vulnerable? So that being said, those are three overarching, but I'm just going to mention, and you'll see this in the brief, which I believe will be, the link will be disseminated after. We framed this around three priorities. One, the first priority being ensuring that people are at the center of processes and that approaches are framed around enabling a high quality of life. So framing efforts around this, looking at a person holistically, looking at a system holistically, looking at a facility. It's not just through the HIV clinic. It's also through the sexual reproductive health clinic. It's through primary care. Maybe it's a mother bringing her baby in for some under 5 vaccines. It's all encompassing, and looking at the person as a whole is going to be really essential. The second priority is building stigma reduction into facility-based quality improvement approaches. So we've talked to Emma, for example, talked about some approaches as well as Karen did. And we see that we talk about different interventions, but if we're able to think about it through a quality lens, and that everyone walking through those doors deserves quality care, and integrating that into the system, the outcomes could be favorable. And then finally, the third priority is ensuring that approaches to reducing stigma engage structures and systems. So we heard from Karen, I mean, healthcare providers are implicated deeply in stigma and discrimination issues, right? But it goes beyond that. We also need to make sure that the healthcare providers and healthcare providers living with HIV are feel supported and are in enabling environments that enable them to be upstanders. So not someone who sits by and watch something happen with stigma, or a discriminatory policy or a discriminatory behavior of one of their counterparts. But the systems enable them to do this. And so those are the three priorities. And I mean, I could go on and on, but I know we have limited time. So with those three priorities, I really just encourage everyone within the brief, we walk through the three priorities, explaining it a little bit more, but also outlining and highlighting, bulleting some very key concrete actions that can be taken.
Okay. Thank you very much. It is very clear. We could hear you even more. But maybe just how you expect the country can take really the best use of this toolkit, kind of. I mean, what would you suggest to take something very pragmatic out of such a document, a technical brief? Because, you know, sometimes from the implementation, from the very good documents to the implementation, there is a gap. So how would you think they can make best use of it?
Right. Yeah, so that's a question that I think we all sort of struggle with in terms of implementation. So in the brief, there are some case examples, including Emma's example of the total facility approach and other ones throughout the globe that have been able to put into practice some of the concrete actions that have been highlighted in the brief. So one, I would encourage providers, facility managers, as well as countries to have a look at these and which can help start generating ideas. I think it's important to, the other issue is it's really, really important to include affected community members as well as just community in general when thinking of any innovation. I feel like a little bit of a politician because I'm dodging your question a little bit because I actually don't have an answer. How do you take like these ideas? It is a policy brief, but if you read through it, it really is concrete. So it's beyond policy. If you're able to work with your community and work with stakeholders, as well as, of course, your ministry, your facility level providers and management, as Emma did with her program, I think that there's, again, concrete actions that can be taken and move forward. And it's really going to be one step at a time. I think the other, again, just to reinforce what I mentioned about quality, and if we're able to approach this through a quality lens, that makes it more systematic. And most countries, most facilities already have some sort of quality management, quality assurance policies within. So, you know, piggybacking on those is another really a good way to move this forward. I hope that answered your question. Over.
Yeah, thank you very much. It does answer my question. So now it's time also to take some questions from the audience, and I have received the first question that I will share with you. So the first question for the panel is we have had some questions about the role of communities in combating stigma and discrimination. So can you tell us what community-led organization can do to support people who have experienced human rights abuses when seeking healthcare? I don't know who from you would like to answer this question.
I'm happy to start.
Yeah, please.
So as I think I was actually finishing on that note, I think community-led monitoring and involving the community from the baseline, and community means, you know, beyond affected people. Community also, again, let me reemphasize, includes healthcare providers living with HIV. So in this brief, there's also some examples. For example, Cambodia really wanted to highlight the message of you equals you. It was actually the community that approached the facility and said, we know there's a policy in place, can we work with you to disseminate this message? So together they joined and had a really great campaign on disseminating the you equals you message. So this is just one example, but it's essential, it's fundamental. It probably won't work. Any intervention probably won't be successful without, you know, community engagement. Over.
Thank you. Emma and Karen, maybe you have something to add on this question of community.
Well, I also wanted to answer one of the questions that I see on the Q&A box, especially around justice and reporting mechanism to protect the community. While there are some reporting mechanisms in place, many women lack confidence in those mechanisms. It will all actually always depend on what country or region are we talking about, but this lack of confidence and some of the barriers are systematic. It is complex, it is a lengthy complaint processes, and there's this belief among women about us women, not only women with HIV, but women in general, that these mechanisms rarely result in meaningful outcome. They will actually have access to justice. In the report, we also did a qualitative study, and we find out that about 14% of women reported experiences of coercion and mistreatment did not report due to fears of retaliation or even further stigma. We also did a regional analysis based on the Stigma Index on West Africa. And almost 90% of women who experience right violations did not file a complaint. And many women fear that reporting could lead to further harm. They can get fired from their jobs. It can harm their family, and actually will just get stuck in the process and will never actually have a result. They anticipate even the same or worse treatment if they speak out based on the past experiences with healthcare. And this lack of faith in the systems means there are very few cases that are reported and fewer cases to receive any forms of redress and justice. And addressing about how can we support the communities and with peer support as important to restore trust for women who have experienced violations, supporting women to achieve justice and change when they have experiences HR violations and of abuses, work with community-led responses as well, because we are also on the ground actually working with women in grassroots organizations too. Hope that answered the question. Oh, sorry. Can I also point out one of the QA boxes that I saw?
Of course.
They are any laws protecting PLHIV. I also want to shout out a really good database from the HIV Justice Network, that you can see any laws protecting HIV or if there has been any criminalization done in your country. It's really interested and you can look more about retaliation and access to justice. Thank you.
Thank you very much, Karen. In fact, I also wanted to ask this question to the other panelist member, because the question of accessing justice is extremely important. There's a lot of questions about that. So I don't know if, Emma, you have some perspective on accessing justice for this discrimination.
No, that was not what I was going to talk about. I was going to talk about one of the ways in which we've improved stigma and discrimination against key population has been to include them in the training. So during the training, we bring key populations into a panel discussion so they have a panel discussion with the nurses, and they tell them some of the challenges they face with the nurses. So for the first time, the nurses are able to empathize with them. They are able to express some of the things the nurses do and how it hurts them. And this helps the nurses to reflect and change some of their stigmatizing ways. So those are some of the things that can be used to reduce stigma by health workers.
Thank you, Emma, because you're just now talking. I have another question for you. So did you see a change in behavior relating to the coercion of women following your intervention? So did you see a change in behavior after your intervention, and what was it?
Yes, there was a change there was a lot of changes, and one was about nurses' fear of HIV transmission during care. And we had a change from baseline 56% of nurses were afraid of contracting HIV just by caring for patients. But after the intervention, when we did the end line, this had reduced to about 29 percentage points. And this was very high. So yes, there was a lot of changes due to the intervention.
Thank you very much, Emma. I now have a specific question for you, Karen, if I may. So could you elaborate on the specific strategies used to ensure the accuracy and reliability of the data that are collected, particularly regarding sensitive topics, such as abuse, for example? So it seems it's not so easy to collect those data. How can you go further than just being this difficult? We don't hear you, Karen. Yeah.
I can talk about on the stigma, the PLHIV Stigma Index approach. The Stigma Index approach is by and for the community. It is a peer-led research that is with the purpose of not to be an academic paper, but to be an advocacy tool for communities to use. So we encourage for the community, we not encourage, the community is leading the study technically and on the ground. The interviewers are peer-led researchers, are people with HIV. And for the coercion report, we also had women with HIV who were part of the research team, interviewers, and have also similar experiences in this. And this can create a safer and more reliable environment to share experiences more openly and lean less and more understood and less distinct. That answer the question.
Yes, thank you very much. There is now on the chat a question specifically to you, Erica. So what is WHO stance on engaging Ministry of Health to domesticate around coercion and abuse of person living with HIV by healthcare workers? If there's something that is, at more highest level.
Yeah, thanks for that question, but I think I'm going to have to defer because I'm not sure I'm actually equipped to answer that question at the higher level. Obviously in terms of stigma and discrimination in healthcare settings and what we're doing, working with countries and ministries to try to make sure that it's part and parcel of their programs, of their national strategic plans, that they're putting funding towards this. That's sort of part of the role of WHO in the discussions with Ministry of Health. But beyond that, in terms of, coercion and stuff, I would say that's, I guess I'm not comfortable speaking at that level, but I'm happy to follow up with people who have more knowledge. I would also say that some of this is also, given policies and laws, is also within UNAIDS realm. But I'm happy to take this to my, my working group and try to get a better answer for you. Thank you.
Thank you. That would be more than welcome. So now a question for everyone. I think it's, are you aware of efforts to use the media, including the social media, to address the issue of stigma at population level? And do you know of any that have been shown to work? And so we will be interested to hear from all of you.
Can you repeat the question? I'm sorry.
Yeah, sure. So are you aware of efforts to use the media, including the social media, to address the issue of stigma at population level? Maybe Karen?
Well, we had during the AIDS conference, with the support of IAS, we had the social media team, that is Gen Advocacy Media Team. And it was really wonderful to see many young women living with HIV who were just starting their advocacy journey, joined the media team and report on the conference, but also in the sessions. They interview key people during the conference. They shared videos of what we saw in the day during the conference, and they did their own kind of media campaign around stigma discrimination and how can it be in a feminist approach, with woman-centered, leading also by young women living with HIV. And that was the first thing that I popped up to my mind, because it was an amazing project that we had. We will recreate it again for the IAS 2025. But you can involve the community in those media strategies, and they led the way for these advocacy efforts in talking about the stigma and discrimination, not only within our core group and the conference, but also posted and have it in the social media, in Twitter and Instagram. We had lives, and they really needed the resources, and they took advantage of the resources, and we saw it.
Thank you very much. I don't know if someone else on the panel wants also to address this question of the social media and social media.
Sure. Well, so about 2 years ago, I was honored by attending a West African group that got together ministries of health as well as other key stakeholders in Ghana to discuss stigma and discrimination. And in that meeting, journalists, sorry, I'm not being articulate, journalists were invited. They were part and parcel of it. And these journalists had already had established relationships with people in the ministries of health and other stakeholders, so that they were duly sort of educated around HIV transmission, STIs, so that then their reporting was accurate, right? So that's one, it's just an example. It's not work that I've done, but I was really, it struck me. And the other is, when we're talking about quality of care and when we're talking about feedback mechanisms, it's also another really great, social media can be a really great platform for that. There's lots of online surveys people can take, or there's online questionnaires after someone's been in a healthcare facility where they can anonymously sort of report back their experience. And that, again, the more data, the better. Well, often the more data, the better. So there are platforms and avenues, and I think more and more that's coming to a forefront. I also was able to attend part of a bi-regional meeting in Asia Pacific region recently, focused on young key populations, and stigma and discrimination, of course, came up there quite a bit as well. And they're really advocating, and the young people are really are obviously attuned to the social media both the campaigns and feedback mechanisms. So I would say for sure there's a role, and I think more and more so. Over.
Thank you very much. Emma?
Yeah, so we recognize that social media plays a very big role. And recently we started a new stigma program in Ghana called the Expanded TFA, which hopes to include pre-service students. So they are taught stigma at pre-service before they come to the in-service. And one of the strategies we are adopting is to put it on all the social media handles, Twitter, Facebook. And so media plays a very important role, and it's recognized.
Thank you very much. So we are 3 minutes from the end. So I have a final question. So please answer with more than 1 minute per each. So it's a question for everyone. So what one specific thing would you say is the most impactful thing that healthcare providers can do to reduce stigma and discrimination? So just one thing that you think it's most impactful. One for each.
Listen to us and our concerns and respect our body autonomy.
Great. Emma?
Empathy. Healthcare workers, once they are trained to empathize with people living with HIV, they can reduce stigma.
And Erica?
I would say, I'm putting on my clinical hat right now. I would say, look internally, look at your own internal biases and really assess as a healthcare provider what you're coming with, and be completely honest with yourself about that moving forward, you can make the changes necessary.
Excellent. Thank you very much. I think we have listened and learned a lot of things during this an hour, but unfortunately we have run out of time and I need to draw this webinar to a close. So the webinar recording will be published on the platform IAS Plus alongside with the recordings of the previous webinars. And I would like to thank you all for attending this webinar, and I apologize for those of you who have not had a chance to ask their questions. And finally, really a big and warm thank you to all the panelists for their contribution today. I think it was a very interesting webinar. It's not the last time we will talk about stigma and discrimination, unfortunately, but I hope it will go to an end as well. So thank you very much and have a wonderful afternoon for those who are in the European time, and a wonderful day for the others, and wishing you a safe and nice day. Bye-bye.